transient ischemic attacks. They're abbreviated TIAs. What this situation is a temporary loss of blood flow to the brain. It's not a stroke. It's usually sometimes termed a pre-stroke. It's reversible, whereas most oftentimes stroke is considered non-reversible. But it's extremely predictive for future strokes. Patients that have a TIA or a transient ischemic attack. So there's a narrowing of the artery that's taking place. If this is a carotid bifurcation in a patient, this is the normal lumen diameter, and you can see here how it's narrowed and compromised. So there might be a situation in this particular patient where they're having ischemic episodes that feel like they're having little mini strokes. They might hear sounds that aren't there, see stars, start behaving strangely, slurring their speech, even passing out. And there's no damage to the brain tissue because the blood flow is reestablished. And so it's reversible. But usually that's a huge clue to the patient and the family that there might be a future stroke that's actually going to occur. About a third of all patients who develop TIAs later experience a stroke. Now, in the case of a stroke, we see what we call cerebral infarction. So in this histology, we're going to be looking at gliosis. Gliosis is the damage to the neural tissue in the brain after a stroke. And it almost looks like this was a photograph and somebody put a glass of water on top of the photograph on the coffee table, and then it sort of created this ring. You see this ring right here? So this is this area of cerebral infarction that we're going to be zooming in these subsequent panels. Now, in A, you've got this acute infarction ridge that we're talking about. So here's the border on your right side, and here's kind of the border on the left side. If we move over to the right, we look at panel C. So this is A, this is C. We're zooming in to one of these regions right here, and we're actually taking a look at infiltrating neutrophils within this infarct. So all of these purple dots are the neutrophils, which are our first responders as they come in. The result 10 days later in panel D. So this is panel D down here. We can see in panel D that there is gliosis that's beginning to form. These are central nervous system macrophage-like cells, which are glial cells. Right? And those are all the black or the dark purple dots. They're not black, they're dark purple. But these are sort of our secondary responders. The glial cells that are microglial cells that would be having a macrophage-like function in the neural tissue. And then in E on the far right, lower right, you can see this scarring right here, this fibrotic scarring, just like what you would expect like in a skin lesion. But we call it a gliosis because of the involvement of the glial cells in creating this scar. So that's the end game if we have a cerebral infarct. If we cut off blood flow, it's compromised to the tissue of the brain, and it's not reversible. It's not a transient ischemic attack. It's actually full-on occlusion. We end up getting this gliosis. Now, the good news is, to this bad news, we have a variety of different therapeutics that we use today, and many of them are very effective. So, number one, we use a lot of pharmaceuticals, a lot of drugs. The drugs that we use are things that are going to maybe prevent the coagulation of the blood, so you don't get thrombotic events taking place in a damaged vessel. So if we look at the cross-section through a normal carotid artery, at the level of section here at the bifurcation. We can see how the lumen is wide open. And here you can actually, I think, appreciate if there's damage to the lumen, then the yellow outline is showing how the lumen flow can be compromised. So here's another way of looking at it radiographically. Here's the lesion right here. You can see a very thin, this is a radiopaque dye that's injected. So they put a probe inside of the vessel in the neck, and they shoot contrast agent that is usually like a barium sulfate. It's radiopaque, meaning it shows up black on X-ray. And so you can see the black contrast agent as it's sort of, in air quotes, kind of dyeing the inside of the lumen. And here it gets through, otherwise the distal or the downstream, which is up toward your head, this lumen wouldn't be filled, but it's filled because there's a little string of black between this point and that point. But that's the narrowing that we're talking about here. And so one of our therapies is we can actually put a stent inside there, and we can inflate that stent. Here it is coming into the lesion. You inflate a balloon within the crushed stent, deflate the balloon, pull the balloon out, and it leaves the stent behind. This is called an endovascular stent placement. Endo meaning inside the blood vessel, and you've left behind a stent to hold it open. A lot of times we'll put these patients also still on drugs, and the types of drugs that we're using, pharmaceuticals, are things like Plavix, which is an antiplatelet drug therapy. Persantine is another one. Over-the-counter aspirin. Grandma and grandpa might be on a daily aspirin, and that's usually considered a good strategy for our elderly population to make sure that they sort of mitigate. Aspirin has a lot of anticoagulant activities within it. And so if grandma and grandpa are on a daily aspirin, it's because they're pharmaceutically trying to keep this from taking place, so they don't have to do this. So these are the different types of therapies that, that we can use to treat these types of events. Now, if we continue on our quest, again, today is a lot of different disease states, and we're not going to cover all of them. Okay? We're definitely not going to cover all of them. Again, we usually do 2 weeks of this, but we've taken a little bit of time off, so we'll talk a little bit about Alzheimer's, we'll talk a little bit about some of these other diseases, but again, if your disease of choice isn't on the list, I do apologize, we just don't have an unlimited amount of time.
Is there a reason baby aspirin is used usually over just regular aspirin?
Well, just because from a dosing standpoint, yeah, it's a little gentler on the stomach. Right? Aspirin, if it's taken without food, it can cause a little bit of intestinal bleeding. And so the baby aspirin is just a lower dose, and it is absorbed a little bit slower. It's a little bit gentler. All right, let's talk about brain trauma. So these are all vascular issues that we've been talking about almost thus far. Now we're kind of shifting gears in the lecture to looking at other types of damages that can take place. And this could either be blunt trauma or open trauma, meaning the cranial cap has been compromised, and so there's actually contusion into the brain itself. But even with just blunt force trauma, where the head hits an object or an object hits the head and the cranial cap is intact or maintained, you can still have traumatic injury. We have 2 types that we want to describe here. One's called coup and the other one's called contra coup. So a head injury that's a coup injury is where there's a injurious location or site that's immediately underneath or deep to the impact site of the object. And the contra coup injury is where there's trauma at a location, and then because the brain itself is floating within the skull cap, that force can actually shift the brain to the other side of the skull and cause a contra coup injury site, which is on the other side of the head. So coup would be right underneath where the head was struck, and a contra coup would be on the other side from where the strike took place. And you could have both at the same time, which is very common in serious traumatic injuries. In other types of injuries that take place, again, trauma, we have diffuse and focal injuries. So the diffuse injuries are all over. There may not be blunt force trauma at all. A lot of times we call this diffuse axonal injury, and most oftentimes it involves some sort of acceleration type of force that takes place. The most common one, unfortunately, we see is shaken baby syndrome. So the shaken baby syndrome is a terrible thing for us to read about in the news, but it does happen. And what's taking place here, as the infant is usually trying to be calmed down because mom or dad is just at their wits' end, they don't know what to do, they're exhausted, and so they kind of shake the infant as they're acting out their frustration. Well, this can cause, in these young individuals, a shearing type of twisting motion. And it happens all over the brain, not just in one location, because the whole individual is being shaken. So this twisting injury can cause tearing to take place at the level of the axon. And in the central nervous system that regeneration doesn't really happen with nerves at all. It can happen in the periphery, but not in the central nervous system. So once you lose many of these axons, they will move on permanently to be dead. And that can actually kill that individual. The focal are grossly observed, and they fall in these categories of contusions, concussions, hematomas, and hemorrhages. And so we're going to look at each one of these here in the next slide. So concussion, first up. What is a concussion? So a concussion is defined as a loss of consciousness. There may be a temporary respiratory arrest where the patient stops breathing. They have a loss of reflex activity because they're not consciously awake. And there could be retrograde or anterograde amnesia. They forget things that happened before or after the event for a period of time. There's no contusion. A contusion is damage to the brain tissue. So there's no actual laceration or damage to the brain tissue. And the amnesia means that they forget things. That's what amnesia stands for. The cause is really unknown. The thought process is that if a strike is aggressive enough, there can be sort of a kind of resetting of all these neurons as they're being smacked. I mean, you know that you can mechanically flick a neuron or push a neuron or trigger a neuron mechanically, and that's, reflexes. You go to the doctor and they strike a certain location, and then your leg twitches. Okay, so you can actually cause an action potential to occur if you mechanically stimulate a nerve. So we don't really know why it takes place, concussions, but we actually know how most of them occur. And you can see, here's struck by a person versus assault versus struck by an object versus collision versus falling. Okay, and this is all in children. And I can attest to this, that they do happen. And a lot of those categories, like a fall and struck by an object, are far more common in my household and to lead to a concussion. And it looks like that's on par with the graph. Okay, so fortunately they weren't striking each other, but one of them fell, the other one got struck by something. So contusion, again, focal injuries, grossly observed, damage to the functional tissue of the brain, the parenchymal tissue. There's a lot of times necrosis or a laceration. There could be bruising that takes place or that's seen. And so in this particular picture, we're seeing changes that take place over here on the patient's left side, where we've got bruising and damage that's compromised this whole section of the brain tissue. So that's a contusion, which is uniquely different than a concussion. The hematoma category, our third category, is where blood leaves the vasculature. And so you get an accumulation due to a tear or a rupture of a vessel. And there's usually three types, depending upon where they are found: epidural, subdural, or subarachnoid. Now, the subarachnoid is often commonly associated with a contusion. So the other thing is, concussion can exist all by itself, and many times it does. Football players, lacrosse players, hockey players, okay, chess. This can all lead to concussions, okay? And it happens pretty commonly. But oftentimes there's no physical trauma or laceration to the brain itself. If there is laceration, and you tore a vessel, and you've created a hematoma in the process, then you're going to have a contusion with a hematoma. Does that make sense? How you have both at the same time? So here's an example of a hematoma that's actually developed epidurally, right? Just on top of the dura. And that's why it looks so bloody on the surface, is because it's right above the dural layer of the meninges. Now, if you look at this diagram up here, we can see the difference on your left side, the patient's right, and your right side, the patient's left. This is characterizing an epidural hematoma, which is usually filled with arterial blood, because the fracture is usually in the meningeal artery, which is ruptured. The skull is cracked right here, that tears that artery, and then you get this dura peeling off the skull and this filling with arterial blood. And that's what you're seeing right here. This is arterial blood. Subdural, beneath the dura, is usually venous blood, because of where it's located, and the tear that takes place between the inner and the outer membrane allows for blood flow from the superior sagittal sinus to kind of collect. Okay? Now we have a couple of other ones to describe here. So here's an intracerebral hemorrhage, and we're going to talk about hemorrhage on the next slide, and that's active bleeding. Here's a subarachnoid hemorrhage, where it's not just pooling of the blood, it's in the process of actively bleeding. So you might have heard that someone would say, okay, so-and-so had an injury, and we're worried about brain bleeding. That's usually how they describe it. We're worried about brain bleeding. So there's definitely concussion, but now they're sort of recovering, and everything's kind of sort of quote-unquote stable. But we just don't know yet. We're not in the clear. We just don't know yet, because we don't know the extent of the damage, because the swelling hasn't come down, and we have bleeding in the brain, and we just don't know yet if it's stopped. So the translation of that is, the patient was in a car accident, had head injury, okay? Lost consciousness temporarily, regained it, is being treated for head injuries, and they say, okay, the good news is we don't think there's a contusion where there's any laceration to the parenchymal tissue, but we probably have seen a vessel torn somewhere, and we're getting bleeding in the brain. And we just we need it to stop. We really hope that we can get the bleeding to stop. If the bleeding is not stopped from a vessel rupture, then it's hemorrhaging, and it's actively a brain bleed. Once it stops, now it's hematoma. It's just a collection of blood. Okay? So the hematoma often results, almost always results, because you have the blood there and now it's pooled. What are some other causes? I talked about trauma with the contusion. The other causes could be things that are unrelated to trauma, like an aneurysm or hypertension, right? You know, don't strain so hard, you're going to blow a blood vessel, right? You tell that to your friends. Well, it's actually not bad advice. Now, if you strain on something, can you rupture a blood vessel? Not as likely as if you have high blood pressure. If you have hypertension, there's a greater chance that a vessel could rupture at a weak spot, like what we talked about right here. And so patients that have high blood pressure or hypertensive are at risk of developing these aneurysms. You can see where these aneurysms occur. The way that I like to describe this is, I grew up in the valley, so in Glendale, if you left your hose out for a couple of summers in the backyard, then the casing would crack, right? And so if you attach it to the spigot and you put like a nozzle on the end, you turn on it full blast, where the casing is cracked, you're going to get sort of this bulge coming out. Does that make sense? So that's basically what an aneurysm looks like. It's a bulge of the vessel because there's a weak location in the wall. And that is, if it ruptures, if this aneurysm ruptures, then it's at risk of creating this active brain bleed, which would be a hemorrhage. And so you can see that here's our circle of Willis, for those of you that don't remember what we were talking about. And in all the different locations within the circle, you can see that there are certain percentages associated with where these aneurysms are likely to take place. So here is an example. Do you see this tissue that is kind of blown out right here? This arrow, this white arrow is pointing to it. Can you see what I'm circumscribing? That is a saccular type aneurysm that's taking place. Here on the upper right that we're looking at, this picture is showing basically the result of a hemorrhage that took place due to AV malformation that took place. So an arterial venous malformation, where the artery meets the vein, there could be an abnormal connection, and it's a weak location, and that's at risk of bulging out. Okay? So saccular aneurysms are about a third of all the cases that result in hemorrhage, saccular aneurysms. So saccular aneurysms that we're showing, this same picture before, here's a saccular aneurysm. Here is a different image with contrast agent of a saccular aneurysm. So this blowout right here should actually connect really cleanly to this line. Here's the inflow, here's the outflow, and this whole wall just sort of blew out. Okay? Here's histology. Here's part of the vessel right here coming down. Here is the aneurysm, and then here's the rest of the vessel coming out. So it should go from here and up through here, like that. And this whole side blew out. And it's called saccular because it looks kind of like a sac hanging on the edge of the blood vessel. Questions?
Does the vessel blow out all at once, or does it grow with time?
Does the blood vessel blow out all at once, or does it grow with time? So yes and yes. It can happen either way. Most commonly, an aneurysm forms, and it goes through a phase of sort of clinical latency where it's not complicated. It has no clinical issues associated with it. It's undetected. And if it grows large enough that it's putting pressure on certain parts of the brain, the patient might start complaining of headache or vision issues. And then they go see their doctor, like, I'm getting headaches every day, or I'm having, some of you are like, oh crap, I got saccular aneurysm. No, you probably just need like another caffeine fix, to be quite honest. But the chances in this room of there being saccular aneurysms, you have very young vessels, it's very unlikely. Okay? Older population is usually who's at risk. So they may become symptomatic when the aneurysm gets large enough. If it ruptures in the brain, there's usually not enough time to treat. Okay? Usually they're going to pass out, paramedics are going to come, they rush them to the emergency department, and if they make it, they're going to go immediately into surgery, and it's kind of a flip of the coin. I don't even know if it's 50-50 at that point. I don't know what the survival rate would be. So we talked about vascular issues, and then we talked about trauma, and then we kind of talked again about vascular issues. And now we're shifting gears in the remaining time. We're going to be talking about sort of this others category. And this others category usually took a whole other week. Okay? And so you're going to see on your post quizzes, you're going to see questions that span kind of two areas within the nervous system of pathologies. One that's kind of related to brain disorders, and others that are related to like trauma, contusions, aneurysms, those kinds of types of questions. Okay? And again, sticking with the theme that hopefully you understand, it's intentional that the post quiz is a little bit more challenging. I'm trying hard to train you for even beyond this class, guys. I want you to figure out, okay, how do I lean on what I do know, and how do I leverage that to go find the answer of what I don't know, and how can I be confident that the source is a good source, okay? And that's truly important. It's not important that you always know the answer. It's more important that you can figure out what the answer is if you need to, okay? So, let's talk about meningitis. Meningitis is actually very relevant because we've actually had issues on this campus. Okay, meningitis is very common in areas like college dorms and military barracks because of the high density of the housing. There's the potential for a lot of bacteria to be present. And that bacteria can cause specifically meningitis. It's very common in the very young and the very old. So the very young and the very old tend to present with streptococcal pneumonia. That is a infection, a bacterial infection that targets our pediatric and our elderly patients. And then Neisseria meningitis is what usually targets college age and our middle age population. Okay? So writing that sentence, I just put myself in with you guys. Okay? So college age, middle age is Neisseria meningitis, and Streptococcus is pediatric and geriatric. All right? This is an infection of the leptomeninges. The leptomeninges is the combo between the space of the dura matter and the subarachnoid matter. The etiological agents could be, the causes could be bacterial, like we just talked about. Now also you could have viral or fungal meningitis as well. The symptoms are neck stiffness, headaches, sensitivity to light, so photophobia, sensitivity to light, and general irritability. People with meningitis sometimes don't act like themselves. Like we had a close friend who was diagnosed with meningitis, and we were all kind of chatting like about how weird she was acting. Like she was kind of acting strange, like not herself, like almost like a different person, really grumpy, and come to find out that she actually had meningitis. And so you can see this is meningitis here. It's the bottom of the brain. So the brainstem would be coming out at you in this picture. So this is the posterior aspect, inferior posterior aspect of the cerebellum. And this is the underside of the cerebrum. And this white pus is where that bacteria is creating this pyogenic infection, where it's purulent, it's creating pus. Meningitis. The next one up that we're going to talk about is Creutzfeldt-Jakob. Creutzfeldt-Jakob is a very interesting disease. What we're learning now about a lot of neurological disorders that target the brain is there's an awful lot of mutated prion activity that's associated with it. So what are prions? Prions are components, are cellular proteins. They're components of proteins within the cell themselves that are termed prions. And we have them in all of our cells and throughout our body. Now, what the problem is if they become mutated, they can actually cause structural deviations of the tissue. And so a mutated prion is really what the problem is here. And so you can see on the upper right, we've got this normal prion. Okay, so this PRP-C is a normal prion. And this PRP-SC is actually a spontaneous conformational change, or a mutated prion. And in some cases, the mutated prion will bind to a quote-unquote normal prion, and it may stay that way, or in many cases, it will form into an aggregate of two mutated prions, or two spontaneously conformed prions, and they form these aggregates. These aggregates actually form within the tissue, and they start in some cases forming vacuoles or spaces as the tissue reorganizes around the aggregate of the mutated protein. If we're talking about neural tissue, then the neural tissue starts becoming incorporated with aggregates, lesions, and those lesions create these giant vacuoles, or these holes. And in Creutzfeldt-Jakob disease, when this takes place, the tissue itself starts looking like a sponge, because it has all these holes or all these vacuoles. And as the tissue changes with the mutation of the prion aggregates and the vacuole formation, you're going to get changes in neuronal function. So the organism is going to start displaying evidence of dementia, because their neural tissue is starting to basically erode away. It's remodeling is what it's doing. And as the protein aggregates are forming these giant spaces or vacuoles in the tissue, it's turning into more of a sponge-looking tissue than normal neural tissue. The synonym, or the related disease in cattle, in bovine population, is called bovine spongiform encephalitis. In sheep, it's called scrappies. And it's from this mutated prion that's forming these aggregates in the brain. We've also referred to it in the cattle population as mad cow disease. So Creutzfeldt-Jakob in cattle is mad cow disease. And there's been times in our history, our recent history, where certain cattle populations have been contaminated with mad cow. And there's all these travel warnings. I remember one year I was traveling a lot to Europe, and in the UK there were a number of herds that were infected with Creutzfeldt-Jakob and had the mad cow disease, or the bovine spongiform encephalitis. And so we were instructed as good company travelers not to eat meat in those particular locations. So we were always eating fish or vegetables, no broccoli. Potatoes, those kinds of things. So, and the reason for that is these prions spontaneously mutate. But it's very rare that they do this, okay? The spontaneous mutation happens extremely, extremely rare. Like 5 to 10% of all the cases in humans that have been accounted for, and it's a rare disease, have been due to the spontaneous mutation of these prions. Now, we're starting to see that these prion disorders happen in other types of dementia-related diseases too. It's not just with Creutzfeldt-Jakob. But the most common way for Creutzfeldt-Jakob to transfer over into the human population is by eating contaminated meat. Okay, and that's why there's these warnings. So how does the cow population become contaminated? Well, unfortunately, I don't want this to be a lesson on the beef industry, but it's kind of a little disgusting, to be quite honest. Okay, so a lot of times the way that they'll terminate cattle, okay, is by punching a hole in their head. And when you punch a hole in their head at the slaughterhouse, it's very efficient, it's very inexpensive, but then all of that contaminated neural tissue gets everywhere, right? And it's not like it just goes, right? It like punches and it goes, okay? So now you've got this contaminated tissue everywhere. And the other thing that the practice has been fairly prevalent is the meat that's not considered appropriate to sell to humans, they put back in the feed. Okay, so now you're feeding the cattle leftover stuff from the slaughter yard, and it's all contaminated chow, if you will, for lack of a better term. Okay? So that's what's going on. We have not had these issues in the United States. These mad cow diseases have happened outside of the U.S., There's a lot more regulation that takes place here on the beef industry. But again, this is what's going on. So that's why if you do a lot of international travel, we haven't seen right now, there's this Middle East respiratory syndrome, MERS. So that's the one that's on the radar in parts of Asia and the Middle East you have to worry about. No mad cow issues right now to be concerned about. So I do have data here. Creutzfeldt-Jakob has a prevalence of 1 case per million. 1 case per million, which is about 1/10,000th as prevalent or less prevalent than Alzheimer's disease. So Creutzfeldt-Jakob isn't really something to worry about. What's really something to worry about is Alzheimer's. So that's what we're going to talk about here in a second. But before we leave there, let's take a peek. On the left is histology. Actually, this is immunohistochemistry. And this is mutated prion staining in tissue. And all of the brown are these mutated prion tangles. And all of the blue is normal neuronal tissue. Over on the far right, here is a advanced aggregate formation with these vacuoles. Do you see how there are these large white open spaces? Those large white open spaces is that spongiform appearance as the neural tissue, the central nervous system, starts having holes created within it. As these aggregates rearrange, they start making, well, here looks like one right here. They rearrange the tissue to start forming these vacuoles. This little inset is just a giant blow-up of the vacuole right here. I don't know exactly which one, but one of these is blown up so you can actually appreciate that. So Creutzfeldt-Jakob. We'll talk about multiple sclerosis, and then we'll talk about Alzheimer's and dementia. But multiple sclerosis is also a very low prevalent disease in the patient population. But it's still something that we see here in the United States as well as in Europe. Women are more sensitive to it. We already described it as a hypersensitivity. Which one was it? Which type of hypersensitivity was it? It's T cell, so it would be considered what? Hypersensitivity number 4. Very good. Okay, so it's a type 4 hypersensitivity due to the role of CD8 positive T cells. But it doesn't mean that there aren't possibly other cell types involved. Women are more likely to get it. The plaques that take place are due to lesions that are forming as a result of the cytotoxic T cells targeting the breakdown of the myelin. Okay, so you've got down here, you've got myelinated neurons, and here you can see the oligodendrocyte and the CD8 positive T cells that are targeting specifically the myelin. Now, there's also antibodies that are being shown, and there's a CD4 T cell response with antigen-presenting cells. So what's going on here? Well, because it's a type 4 hypersensitivity, that means that CD8 cells are involved. But we also know that antibodies, autoantibodies, are being produced towards your myelin, recruiting antigen-presenting cells to harbor a reaction towards the myelin itself and lead to inflammation of those particular myelin sheaths that aren't necessarily healed right away. When they're actually destroyed, there's a scar or a plaque that forms across the axon, and it decreases the action potential capability of that neuron. So we talked at the very beginning of the lecture about the role of myelin in the oligodendrocyte. Now, some of the interesting facts that we've learned these days is that MS is actually much more prevalent in certain parts of the world. Certain parts of the world that get very little sunlight seem to have higher incidences of multiple sclerosis. So the data does suggest that there may be some environmental sensitivity or trigger that we don't really understand all that well. But the prevalence of MS increases as you move further away from the equator. So the prevalence in our sort of Nordic European nations is much higher than it is, say, in Central America at the level of the equator. Now, what's the balance between environmental and genetics? We don't know the answer to that right now. It seems like there's a trigger with exposure or availability of sunlight, but it's not to say that it's likely that there's a genetic predisposition towards it, like most autoimmunities, and its trigger point, like we were talking about previously last week or weeks before on diabetes, type 1 diabetes, there is potentially this trigger, this environmental trigger that causes these patients to express the genotype. Okay? Now, Alzheimer's. So Alzheimer's is something that we typically spend a lot of time on, and we're not going to spend more than one slide. It is the #1 cause of dementia in our elderly population. So it's the #1 cause. There are other causes of dementia, but it happens to be the #1 cause, Alzheimer's. And we also find these aggregates that form, just like what we see with Creutzfeldt-Jakob disease. We see mutations that take place at the level of certain proteins. In this case, they're not prions, but they are proteins that mutate and form these aggregates and therefore form these lesions. Now, the lesions don't lead to large vacuoles like what we see with Creutzfeldt-Jakob. The lesions lead to these plaques, what we call beta amyloid plaques, and they also lead to these neurofibrillar tangles. And we get both showing up in the brain. Now, it's a chicken and egg question. So when we have patients at post-mortem and they donate their body to science, and we slice through the brain and we look, we do see the presence of beta amyloid plaques and these neurofibrillary tangles in these patients who never were exhibiting any symptoms of Alzheimer's. Okay? But when we do autopsies post-mortem on patients that donate their bodies to science, in patients that have Alzheimer's, they always have the neurofibrillary tangles and the beta amyloid plaques. So the question is, what happened? Likely, we start developing these lesions as we age, and at some trigger point, they get to a high enough density where they start causing dementia-related clinical symptoms. So, it's called the disease of the age, or it's called a disease of the elderly, because it's much more common in elderly patients. And on one of the videos I wanted you to watch, or I want you to watch this week, you're going to see two brothers that are twin brothers. And one of them starts developing Alzheimer's very early, and it doesn't show in the video, but the second brother eventually, like 10 years later, starts developing Alzheimer's-like symptoms. And the thing that's interesting is they're both identical twins. And so they're identical twins, they have the same genetic makeup, yet one develops it 10 years prior to the other. Okay, so it's not always just genetics. There must be some sort of other environmental influence that we can't account for. So let's take a look at this. What happens is, here's our beta amyloid precursor protein. And this is the organization of our alpha and our gamma units. And as this converts over with these cleavage sites, you can see where the alpha secretase and the gamma secretase cut this protein, create a soluble fragment, and essentially this insoluble fragment. Now, the alpha-beta subunit, which is this reddish-like structure, is what breaks off and starts forming these aggregates. And these aggregates move on to form what we call these amyloid fibrils. And you can see histologically sort of different representations in brain tissue or neural tissue. Here you can appreciate more of the amyloid fibrous architecture as you see these little stringy structures coming out. So here. This is organization of the alpha-beta aggregates. All three of these are samples that were taken from patients exhibiting Alzheimer's post-mortem. And then on the far right, you can see a combination of both in this particular slice, where you've got alpha-beta aggregates by the larger structures, and then here are some amyloid fibrils, or what we call these neurofibrillary tangles, Here's some more over here. Here's some in this direction. Here's some fibral tangles here. But these are the lesions that start showing up in the brain as basically a type of scar. And it's starting to compromise the neural function of that tissue. It tends to affect higher functions first. And if you watch the video, what's fascinating, so early signs of Alzheimer's are things like forgetting your address. You're like, oh crap, I don't even remember my address now. No, don't worry, you don't have Alzheimer's, you're not old enough, okay? So the first risk factor for Alzheimer's is actually age. That's the #1 risk factor. It's a disease of the elderly. Secondly, if you've had severe brain trauma in the past, that's another big risk factor. These are risk factors. We don't know why, okay? But brain trauma and age. Okay, bless you. Thirdly, we see that patients who have that are more educated tend to display the effects of Alzheimer's slower or less prevalent than patients that have a lower level of education. Now, it just might be that if you are more highly educated and you can't remember the name or you can't remember the address of where you live, so you make a joke out of it, you know, and you kind of work your way around like, so what's your home address? Oh, come on, you know my home address. Right? I've lived there for 20 years. So what is it? Well, I live in Flagstaff on the east side, of course. Right? Well, what's your address? Well, I live over kind of over on the other side of town. Right? And you quickly can figure out that they don't know they don't remember their address. Okay? What's the name of your brother? Well, I have a couple of brothers. Which one are you talking about? Right? But they can't remember the name of their sibling. They may remember the name of certain objects. So, can you tell me? And these are neuropsychology exams that are done. So tell me what this is called. Oh, come on, we all use it every day. You don't know the name of that? So that might be somebody that's kind of coy with this examination. And there may be other patients that say, well, I don't remember what that's called. But or they can't remember, you know, what's that? Oh, those are things that you use to, you know, to go on the car or open your door. So they can't remember the name of keys or a cell phone or their address. So these are the early signs of Alzheimer's. And then it becomes, this dementia expands where they're kind of almost delusional. And then they'll wander around and get lost because they don't know where they are. They don't remember where they live. They don't remember a phone number to call anybody. It can be very scary. And as Alzheimer's patients progress, unfortunately, it becomes even more challenging for the family because they stop behaving like you knew them, and they almost take on a different personality. Okay? You will be dealing with patients with Alzheimer's if you're in the healthcare industry. There's no question about that. The last one that we need to talk about in our remaining time is Parkinson's disease. So in Parkinson's disease, most of these cases are really idiopathic. We don't know why. But there is a diminished ability of the production of dopamine. So dopamine stimulates the substantial nigra, and the substantial nigra in turn is going to block or inhibit unwanted motions. And so in these patients you're going to see a very observable tremor. Okay, and this tremor will be here as I'm talking to you, and if it bothers me so much, I'll put it in my pocket, or I will interrupt it and manually, with motor efferent activity, block that unwanted movement. But the substantial nigra is part of the midbrain of the basal ganglia. It's dopaminergic. It releases dopamine, and you can see the pigmentation. Here is a normal substantial nigra, and you can actually appreciate the pigmentation right here on the ridge. And this is evidence of large amounts of dopamine that are able to be released. And in a Parkinson's patient, of course, this is post-mortem. people that have donated their bodies to science, you can see a lack of pigmentation where we're not getting the release of the dopamine to block these unwanted movements. So the symptoms: diminished facial expression, a lot of stooped posture, slowness of voluntary movement, a tremor, a sort of a constant tremor, accelerated gait, because a lot of times they'll try to compensate by maybe moving more quickly. Otherwise, if they move too slow, it might be kind of awkward motion that takes place. And by overriding it with motor efferent, you can try to compensate. The patient can kind of compensate by trying to override these unwanted tremors that take place. So that is a crash course to end us on the nervous system. Reminder: there are 2 post quizzes that are due Friday. Okay, 2 post quizzes that are due Friday. And please watch the videos on YouTube that describe some of these other types of diseases that we went over.